Good afternoon. Welcome to the Booker T. Washington Awards Luncheon. We're going to be introducing Dr. Howard Koh, and to do that, I'm going to invite Dr. Maria Rivas, who's the Vice President of Global Affairs within AbbVie R&D, to come to the podium. Maria's role at AbbVie is to lead a worldwide network of 1,600 medical experts serving in greater than 60 countries, whose mission is to ensure that patients benefit from AbbVie therapies. The medical affairs organization Maria leads generates and communicates data and information to healthcare practitioners, payers, and patients to inform their clinical use of AbbVie therapies. It's my pleasure to introduce to the podium Maria Rivas.
Thank you. Good afternoon, and bon appetit, or buen provecho, as they say in my country. Anyway, it is, thank you, Bill, for those warm words of welcome, and it is an honor for me to essentially introduce our guest speaker for today's Booker T. Washington Luncheon at the annual National Summit on Health Disparities of the National Minority Equality Forum. As Bill alluded to, I head a global organization of medical professionals in the Research and Development Department of AbbVie Pharmaceuticals. And AbbVie is essentially a biopharmaceutical company located in the north of North Chicago. And we are essentially committed to our scientific expertise and passion being devoted to meeting the world's greatest unmet medical needs. As such, I cannot think of one greatest cause as such as hepatitis C, where currently we are seeing such wide disparities. In particular, the African American population is very singularly affected and has a high prevalence, not only that, but also of suffering from a high death due to chronic liver disease, a leading cause of death in African Americans between ages 45 and 64. In addition, in the Latino population as well, we suffer from twice likelihood or risk of HCV infection, and regrettably also a high risk of progression to cirrhosis, higher than in other ethnic groups or races. So at AbbVie, we are committed to working with stakeholders like you to address these health disparities in ways that take care of those that most suffer from these diseases, in ways that particularly attend to those with the hardest to treat cases. And for that reason, it is a pleasure for me to introduce our speaker, Dr. Howard Koh, the Assistant Secretary of Health at the U.S. Department of Health and Human Services. Dr. Koh is an ardent advocate for addressing health disparities, in particular in hepatitis C. He is a well-recognized leader in this public health space, a professor previously at Harvard's Public Health School of Public Health. And as an Assistant Secretary of Health, he leads 12 offices, including the Office of Surgeon General, 10 regional health offices, as well as several advisory committees, presidential and secretarial advisory committees. Very importantly, recently, Dr. Koh launched a cross-agency national action plan to address the health disparities in hepatitis C. So with that, please join me in welcoming Dr. Koh.
Dr. Rivas, thank you for that very warm welcome, and thank you so much, everyone, for being here today and for being part of this very, very exciting forum. It's very impressive to see the number of people here and the feeling of commitment to public health and to the elimination of disparities. And so let me start by thanking not only Dr. Rivas, but Dr. Gary Puckrein, Bill Griffith, and for all of you for sponsoring the 11th Annual Summit on National Health Disparities. I know this is a collaboration not only between the Forum, but also the Congressional Black Caucus Health Braintrust. And it's been great to catch up with my good friend and our wonderful leader, Congresswoman Donna Christensen. 18 years in Congress. What do you think of that? So we are very, very proud of her commitment and your commitment to public health and to ending disparities, for the leadership of Congresswoman Christensen. It's great to see my friend, Representative Shirley Nathan Pulliam here from Maryland. I am offering my congratulations to Edward Martinez, who will shortly be receiving the Booker T. Washington Award. And also congratulations to Senator Cardin and my good friend Dr. John Ruffin, who will be honored here tomorrow night. So many wonderful leaders here, so many people committed to improving public health. And I'm delighted that you're having this summit because you have a great mission, a mission to eliminate health disparities for minority populations. At a time like this, we reflect on Reverend Martin Luther King, who had at least two sayings relevant to the summit today and tomorrow. First, he said that he wanted all people to enjoy what he called the sunlight of opportunity. I love that phrase and use that phrase all the time. And let's face it, in health and public health, there are too many people, especially minority backgrounds, who are not enjoying that sunlight of opportunity. Secondly, Reverend King once said, "He who has health has hope, and he who has hope has everything." And what this forum has done and continues to do is to give that hope to all people, not just some people in our country. That's why our country's vision for the future with respect to public health, Healthy People 2020, has one of its overarching goals to eliminate health disparities by the end of the decade and beyond. And I am here because your mission is my mission, and your story is my story. I'm a Korean American who is the oldest son from an immigrant family. My parents immigrated to this country a generation ago, searching for the American dream. My childhood is filled with memories of the lectures my parents gave me and my siblings every day, that we should be grateful for being born and raised in this country of opportunity, that we had an obligation to do something with our lives and to give back to this society, and that we had to contribute to make the society even stronger, especially for those who feel like they are in the margins of our society. For those of you who are of minority background, like I am, you know that growing up as a minority in this country is not easy. You often feel like you are not in the mainstream of activity in this country. And we can't have that feeling spilling over into public health and health care. So it was feelings like that that have driven me throughout my whole career as a physician, as a clinician, as a former state health commissioner in Massachusetts from 1997 to 2003, multiple governors, by the way, and now as the Assistant Secretary for Health appointed by the President in June of 2009, almost 5 years ago, which I can't believe. And as I reflect on these critical themes for our country's health and on the work that you do, I often like to point out that the work that the forum started 11 summits ago is now the mission of the entire country, whether the entire country realizes it or not, because our country is growing diverse by the day. We have some 4 states that are majority-minority states, California, Texas, Hawaii, and New Mexico, where minority populations make up the majority. Of our 15 most populous cities, 7 of them are majority-minority cities. 2011 was an important watershed for our country because that was the first time that of the 4 million births a year in our country, more than half, slightly over 50% of the births were to minority moms. Slightly less than 50% were to majority moms. And it's projected that by the year 2043, that we will be indeed a majority-minority nation. So you are ahead of the curve. You are addressing issues of health for all, issues of health equity, of reducing and eliminating disparities, to make sure that everyone's part of the mainstream of public health and healthcare in our society. And that's why we're very, very grateful to you. And that's why our department, several years ago, was proud to unveil its first ever strategic action plan to reduce racial ethnic health disparities. And we've been implementing that plan every day under the leadership of our Secretary, Kathleen Sebelius. We've been writing about that plan in journals like Health Affairs. We know that we are now living in a historic time with respect to the Affordable Care Act that has many related activities that are aimed at reducing disparities. And that's why you're having this summit that's exploring disparities in areas like cancer, an area that I've contributed to as a researcher, in cardiovascular disease, in kidney disease, and mental health, because you can't be fully healthy unless you have your emotional well-being as well as your physical well-being. And you're going to be hearing more about disparities in diabetes and HIV and many other areas before this exciting summit is over. Now, through it all, the forum looks for areas where there has been relative silence, lack of awareness. And that's why I'm very grateful that several years ago, we all joined together to start paying more attention to the silent epidemic of chronic hepatitis. You may or may not know that this is a condition that affects up to 5.3 million Americans in this country. And basic fact number one about chronic hepatitis is that most people who are infected do not know they are infected. So we have to start with basic awareness of serostatus, basic awareness and education about the public health threat that chronic hepatitis represents. It claims the lives of up to 18,000 Americans each year, and in fact, passed the number of deaths from HIV a number of years ago. And here is yet another area where health disparities disproportionately affect people of minority backgrounds. So we know, for example, for hepatitis C, which affects up to 3.2 million people in our society, this condition is twice as common among African Americans compared to the general population. It's also more common among Hispanics and Native Americans. And then hepatitis B, which affects an estimated 1.4 million people in the country, disproportionately impacts some 1 out of 12 Asian Americans. Half the people chronically infected with hepatitis B in this country are of Asian American Pacific Islander background. And these are some of the reasons why we are seeing hepatitis fueling rising rates of liver failure, liver cancer, and liver transplant. We are concerned when we hear about the disproportionate burden on infection, and we also are concerned when we see that with the older medications for hepatitis C, we had documented that African Americans had lower cure rates than whites. So disparities in treatment response has also been one of our many, many concerns. Now, through the collaboration of the forum, through the medical experts in this room and many others, we as a nation are shining a stronger light on hepatitis, its sequelae, and the disparities that are involved. In 2013, the National Medical Association had its first ever consensus panel report entitled Hepatitis C, a Crisis in the African American Community. And then in January of this year, we had academic researchers and staff from our Centers for Disease Control and Prevention, CBC, publish a new report about Hep C rates across Hispanic populations. And as always, we found tremendous heterogeneity among subpopulations. So, for example, for hepatitis C in Hispanic populations, the data showed that people of Puerto Rican background have the highest rates of Hep C for reasons that we need to understand better. And in fact, for all disparities we talk about, we need more granular data. As an Asian American, I like to point out that the term Asian American is as helpful as the term European American. There's so much heterogeneity. And just in my case, for example, I have family members who were born in Korea who came to this country a generation ago, especially including my parents. And then I and my siblings born in the US, speaking English as our first language. So even within the Asian American and Korean American populations, we have subgroups with differing rates of risk. That's why we are very pleased as a major step forward for the Affordable Care Act was the requirement that all federally funded surveys collect more granular racial ethnic data. So, for example, there are more subpopulations to choose from when tracking data for Asian Americans and Pacific Islanders, some 7 subcategories for Asian Americans, 4 subcategories for Pacific Islanders. This did not exist until the Affordable Care Act was passed. And we need to continue to collect that granular data in hepatitis and in cancer and in heart disease and many other areas so we can better understand the challenges before us and then develop good actions to solve them. So this was a situation that we faced when this administration came into office. And in 2010, the Institute of Medicine came out with a national report on the silent epidemic of chronic hepatitis and asked for more national action and commitment. So we were very proud in 2011 to come out with the first ever national viral hepatitis action plan. I am very, very honored and pleased and proud of my colleagues across government who contributed to this plan, Dr. Ron Baldessari, who is director of our Office of HIV, AIDS, and Infectious Disease Policy. I have here our senior policy advisor on hepatitis, Karina Dan. Karina Dan is absolutely tireless. Karina, where are you? Why don't you just stand up and get a round of applause from our group here? There she is. We have many other colleagues in the department who are here who have been supportive of the plan and leaders of the plan. I see Jasmine Jackson from our Office of Minority Health, Francis Ash Goins from our Office of Women's Health, and many others. And we were also very proud that we could join the whole department together, CDC, FDA, NIH, all these acronyms in government, as you know, not only within HHS, Health and Human Services, but also within the Department of Justice. Very importantly, the Bureau of Prisons. I know there are many heroes here working in correctional health. Thank you very much. That's really important, especially for areas like hepatitis. The VA, and most recently, the Department of Housing and Urban Development. And we're very proud to have all these broad partners around the table with us because public health in the 21st century means that we need every partner contributing in their own unique way to solving public health challenges, whether it's hepatitis or something else. And we need experts who are not in the traditional medical and public health fields to join and be leaders, because health is much more than what happens to you in a doctor's office. In fact, I like to say that health starts where people live, labor, learn, play, and pray. I made that up, so I'll say it again. Health starts where people live, labor, learn, play, and pray. So you can't have your health unless you have a healthy home, unless you have a healthy school, unless you have a healthy work environment, unless you're joining the faith-based communities together, unless you have clean environments and recreational sites for your families and your kids. So we launched this hepatitis plan in 2011 under the leadership of Dr. Baldessari, Karina Dan, also Dr. John Ward of the CDC, a tremendous public health leader. And I am very pleased now to report to you at least 10 major achievements since 2011. In fact, I like top 10s, like David Letterman. I'm not sure he's ever done one for hepatitis, but here it goes, the top 10 for what we've done in hepatitis since 2011. First, we've established May 19th as a national hepatitis testing day across the country, coast to coast, to raise awareness, particularly to raise awareness about disparities. The CDC has a campaign called No More Hepatitis, with the word no spelled K-N-O-W. And we are very proud that we have this nationally coordinated effort that's coming up now in just a couple weeks. Number 2, we have specific awareness days for the Hispanic community. The first one was started in May 2012. And for the African American community, the first one was started in July 2013. Again, because most people who are infected do not know they're infected, we start with basic awareness and the call for education and testing when appropriate. Third, we were very, very proud, and I hope everybody knows this, that most recently the U.S. Preventive Services Task Force, the premier prevention guideline group in the country, put out a proposal recommending that individuals born between 1945 and 1965, us baby boomers, be screened for hepatitis C, because people in that age range are 5 times more likely to be infected with hep C than the general population. So we were delighted when the U.S. Preventive Services Task Force made that a recommendation and came forward with this baby boomer screening recommendation, which hopefully will bring in more people into the system for earlier testing and treatment. Fourth, in 2012, the CDC awarded almost $7 million from the Prevention Fund newly established by the Affordable Care Act, to 35 sites to provide Hep B and Hep C testing and linkage to care for people at risk. Last year, the Secretary prioritized this testing by transferring funds to continue these testing projects, so we want the momentum to continue. Fifth, we expanded culturally and linguistically appropriate hepatitis B outreach and education materials in multiple Asian languages. That was a very, very exciting development for us. And hopefully many of you also know, on a parallel track, we have the release last year of the Enhanced National Class Standards, culturally and linguistically appropriate services in health and health care. We like to say that we want all providers to deliver care with class, C-L-A-S. And so this is one example of that outreach, particularly with respect to Asian American populations. Six, we're focusing special attention to the problem of hepatitis C among people who inject drugs. This is an initiative that joined together our National Institute for Drug Abuse, NIDA, our Substance Abuse and Mental Health Services Administration, SAMHSA, and the Office of the National Drug Control Policy, whose acting director right now is Michael Botticelli, a wonderful public health leader. So again, we're bringing new partners together to tackle this issue. Seventh, we've helped the advocates across the country launch a new effort called Hep B United. And it's great to see leadership in places like San Francisco and DC and New York joining together for this outreach with respect to eliminating perinatal hepatitis B transmission and testing moms while pregnant and giving all newborns vaccinations against hepatitis B in birthing hospitals, what they call the birth dose. And for those of you who have studied public health in depth, I love the birth dose of hepatitis B as a great example of prevention at birth. A child is born, and literally one of the first things that child receives is a birth dose of hepatitis B. That can save a lot of suffering in the future. Eighth, you all know that we have tremendous progress now ongoing with respect to new treatments for hepatitis C, recently approved by the FDA. Treatments that are simpler to take, shorter in duration, fewer side effects, and higher cure rates. Many of you are experts in this area, so thank you. We want to see that progress continue. And I'm grateful to my colleagues from the Food and Drug Administration, the FDA, who are engaged in a hepatitis C registry and research network to monitor outcomes of these newly approved anti-hep C therapies. It would be great if someday we could get up and say that the treatment outcome disparities for hepatitis C have now narrowed because of these new therapies. I'm not sure we can say that definitively yet, but we want to do that. And we also want to bring in African American and Hispanic patients who have always been underrepresented in clinical trials so we can make that gap narrow. Ninth, we're very, very grateful to the White House and to the President for their World Hepatitis Day proclamations that started 3 years ago. This has raised now global awareness on hepatitis that we're very, very proud of. And then 10th and last, but certainly not least, of course, the Affordable Care Act, because we are doing this work in an absolutely historic time. When people ask me what it's like to be the Assistant Secretary for Health in 2014, my answer's always the same. It's life-changing, and it's absolutely historic. And what we're going through day in and day out may not be easy, but it is memorable. It's something that you will always feel is a part of your professional careers that you can be very, very proud of. And so we are at a fundamental moment in our nation's history where we're asking fundamental questions about how to bring better insurance, but also better care and then better public health to over 300 million people in our country. This is the time. You are in the center of that discussion and that activity, and we want to thank you. So as I stand here and as I bring this presentation to a close, we are on the first month of celebrating a second version of a viral hepatitis action plan, our viral hepatitis action plan 2.0, if you will. We have continued commitment to our goals of raising awareness of those who have Hep C from some 45% to some 66% of those infected, raising awareness of those who are chronically infected with Hep B from 33% to 66% in the future. We want to decrease incidence. This is an absolutely preventable epidemic. We want to eliminate perinatal transmission, just the same strategies in many ways as we've pursued for HIV. And we want to do it in the context of this absolutely historic time where we can say that everybody now has access to insurance. It doesn't matter if you have hepatitis or some other pre-existing condition. And we want to develop better care models where people with these complex conditions can receive care in team-based approaches in the way they need and deserve. So what have we done now just in several years? This plan has been, if I can say, one of the most gratifying experiences I've been involved as the Assistant Secretary, because we have aligned the whole country and we have broken the silence. Some people might say, oh, well, this is just a plan and we need to see the results. And of course, that's absolutely true. We need to have more outcomes, even though I've shared with you the top 10, which is very, very important. But I love that phrase, if you fail to plan, you plan to fail. We now have this plan that has brought people together like the Forum, like medical researchers, public health leaders, colleagues across government at the national and state level, advocates, the hepatitis B and C leaders. And if I can say, I am very, very proud of the progress we've made in such a short period of time. And we want to see that progress accelerate and go even faster in the future. And that's why I was very pleased to come and accept this invitation to speak at the forum and to say thank you to each and every one of you. If we can make the progress in hepatitis, almost a model of what we can do in many other areas of public health, this is a way we can teach one another, we can share lessons learned, we can encourage one another, we can show that change is possible, we can show that new collaborations are possible, and we can make our community stronger. My final quote is a quote defining community, which is what we are. And the question is, what is a community? How do we make progress as a community? Well, a community is a place, according to a Swedish proverb, where a joy shared is twice the joy, and a sorrow shared is half the sorrow. And I think because of this work, and because of the work of the Forum and your commitment to eliminating disparities and helping all people reach the sunlight of opportunity, we are making a difference for public health. So thank you very, very much.
Thank you, Dr. Koh, for a wonderful presentation. It's my pleasure now to introduce all of you to Maulik Joshi, who is the President of the Health Research and Educational Trust and Senior Vice President for the American Hospital Association. He is now going to introduce you to this year's recipient of the Booker T. Washington Award. Thank you.
Good afternoon, everyone. It's always difficult to follow Dr. Koh, but it's easy to follow me. So Ed, you're going to be in a great spot here. It's really just a delight. We all have challenges in our daily lives, challenges in our personal lives, challenges in our professional lives, ambitions and goals. but it's always great to take a step and really celebrate also and recognize, and that's what we're going to get a chance to do for this lunch, a chance to recognize Ed Martinez for his accomplishments, his passion, and his drive for the Booker T. Washington Award. So I just really enjoy the opportunity to celebrate with him and with this community in terms of the work he's done. So as Bill said, my name is Maulik Joshi, and on behalf of the American Hospital Association, I'm just delighted to be able to be up here to introduce Ed and to honor him with this distinction. As you know, the award recognizes an individual or organization that has made an outstanding contribution to the promotion of wellness in emerging populations. And Ed, in many ways, represents both individual and organization. You're going to hear when he speaks about his individual passion and his commitment to this work. But from an organizational standpoint, I just want to take a step and just talk about some of what I've been able to observe and be a part of in working with Ed. He's certainly done so much work with the previously the NAPH, but America's Essentials Hospitals, and with Bruce Siegel, our previous Booker T. Washington Award recipient. Ed has also been on the U.S. Department of Health and Human Services Advisory Committee on Minority Health, and before that, spearheaded the work at the Los Angeles County University of Southern California Medical Center, among many other roles. But most closely, over the last several years, Ed has worked and has chaired the board of the Institute for Diversity in Healthcare Management at the American Hospital Association under the leadership of Fred Hobby, president and CEO. And really, Ed's work has been just quite palpable in terms of what he's done in bringing together incredible board leaders, incredible leaders in the organization and the AHA in aligning the work of the Institute for Diversity with the national call to action to eliminate healthcare disparities. That alignment speaks to Ed's vision of seeing that there's a greater opportunity of what can be done. It speaks to Ed's strategy of going about that work, aligning organizations, aligning priorities, aligning goals, and it speaks to his action. Ed was spearheading the board, their work, and very intense. And I think that's what really distinguishes Ed in this work. He's the triple threat. He has vision, he has strategy, and he has action. And that's what we need in healthcare today in terms of equity. Equity of care is not a nicety, but a necessary characteristic of our healthcare system. And we need individuals like Ed to help us take us to that future spot. So to the National Minority Equality Forum, Bill and Gary and others, you've made an exceptional choice. And on behalf of the American Hospital Association, the Institute for Diversity in Healthcare Management, and the Equity of Care Committee, we're delighted to be able to honor Ed as well. So please join me in congratulating Ed Martinez with the Booker T. Washington Award.
Friends, Maulik, Gary, dear family, friends, and colleagues, I would like to sincerely thank the American Hospital Association and the National Minority Equality Forum for this award. Receiving the Booker T. Washington Award is truly an honor and is also very humbling to be associated with past recipients and their contributions to moving the agenda of health equity forward, health and health equity. I would like to thank in particular the women and men of the Board of Directors of the Institute for Diversity in Health Management for their vision of diversity and inclusion in our healthcare C-suites and governing bodies. Theirs is a vision of diversity not for its own sake, but a diversity that is oriented to achieving equity for all of our communities. Our board believes that we need responsive leaders who who can engage in open dialogue and interactions that ensure community influence. A community influence that is essential for informing leadership and governing bodies about the origin, nature, and effects of health disparities on all populations. Booker T. Washington said, "Excellence is to do a common thing in an uncommon way." The National Minority Quality Forum has been doing just that for the past 13 or so years. I commend the forum. Your organization and collaboratives are providing, as few others are, the critical disparities data for progress in achieving health equity. The forum's work has demonstrated in a graphic way what Alan Entoven and Richard Cronick describe as an American healthcare system that is a paradox of excess and deprivation. Your work provides enormous assistance and support to the American Hospital Association and its partners as they pursue equity of care and its national call to action, an initiative established to steer the health field on a clear path to eliminating disparities. The board of the Institute for Diversity in Health Management is committed to working with the American Hospital Association and its partners to impact disparities by focusing on three core elements: increase the collection of race, ethnicity, and language preference data, increase cultural competency training for clinicians and support staff, and increase diversity in leadership and governance. Our Institute board, in collaboration with the Equity of Care partners, is focused on generating a real sense of urgency regarding the need to address the prevalence and persistence of health disparities and the unequal representation of minorities and women in the C-suites and governing bodies of our healthcare organizations. We know the facts about disparities and the lack of inclusion in healthcare. They are compelling and they speak for themselves. We know that due to immigration and minorities' higher birth rates, minorities are rapidly increasing as a proportion of the total US population. As Dr. Koh indicated, minorities will become the majority of the national population by 2050 or before. As a nation, we need to do more to prepare for this monumentous demographic shift. If not, when our vulnerable and under-resourced populations become the majority, the US will be faced with a health crisis of unimaginable proportion. Dr. Martin Luther King Jr. pointed out to us, without hard work, time itself becomes an ally of the primitive forces of social stagnation. So we must help time and realize that the time is always ripe to do right. We know from a Commonwealth Fund study that US healthcare spending amounted to more than 17% of GDP in 2009, probably higher today. And yet the US failed to achieve better health outcomes than 6 other first world countries studied. Further, the US ranked last on dimensions of access, patient safety, coordination, efficiency, and equity. Begging the question, how do we explain our poor outcomes and persistent disparities when we spend so much in the health sector? We know perhaps the most glaring and alarming fact related to health disparities, the public health crisis of US infant mortality in our minority communities and tribal nations. In 2011, the World Health Organization reported that the US had dropped to 41st worldwide in newborn death rates. Critics of the study immediately challenged the rankings as representing an undercounting of newborn deaths in some countries, thereby lowering the U.S. ranking. Researchers have argued back and forth as to the reliability of the rankings, but no one asserts that the U.S. would place in the top tier. The critical issue, of course, as you know, is that U.S. infant deaths are disproportionately high among racial and ethnic minority populations, particularly African American, American Indian, Alaska Native, and Native Hawaiian Pacific Islander. Finally, we know that the C-suites and governing bodies of our healthcare organizations simply do not look like the U.S. We do not see a truly representative number of men and women from the diverse communities of our nation. A 2011 survey of 924 U.S. hospitals sample was representative of all hospitals by the American Hospital Association and the Center for Healthcare Governance revealed that minorities comprised only 14% of executive leadership positions and only 10% of hospital board members. Our Institute board intends to work with the American Hospital Association and its partners to accelerate implementing strategies for addressing disparities and inclusion. These strategies need to be integrated into the performance and outcomes management of healthcare organizations. Outcomes that can be included in organizational report cards that reflect accountability for addressing the needs of all communities. Achieving healthcare equity is both a challenge and an opportunity for any organization. Barriers clearly exist in the form of constrained budgets, insufficient staffing, technology gaps, and the absence of patient data needed to address disparities. However, there is now a significant compendium of research, promising practices, model strategies, and training resources that is available to accountable leaders who are informed about and committed to serving their communities. As Dr. Coe mentioned, the Affordable Care Act also now provides an opportunity for U.S. healthcare organizations to collaborate in achieving genuine health reform that emphasizes equitable quality and the improved health status for all U.S. communities and tribal nations. And one last thought, in particular for young healthcare professionals. Whatever your focus, be it clinical, management, research in hospitals or health systems, be they public or nonprofit, for-profit, faith-affiliated, and however you identify yourself as minority, non-minority, gay, straight, believer, non-believer, we must not forget that we all live in a nation of communities, and that many of these communities are vulnerable and under-resourced and cannot yet make it into the mainstream. We are, in the end, our sisters' and brothers' keepers. I close with the words of American farm worker, labor leader, and civil rights activist Cesar Chavez. We cannot seek achievement for ourselves and forget progress and prosperity for our community. Our ambitions must be broad enough to include the aspirations and needs of others for their sakes and for our own. Thank you very much.
I've known Ed Martinez for a lot of years and know that what he said to you this afternoon is just a rephrase of the work that he's done over the years, and it's been a pleasure and honor to have worked with you. Before we bring up our next speaker, we're going to run a little video. We set out a promise last year at our summit, and so promises made and promises fulfilled. So I want to come back with a promise fulfilled. So if we can start the video, and then I'm going to ask Salvo Alesci from Pharma to come up and speak.
Every day, researchers are developing solutions to these and other health issues through clinical trials. But they're missing something. You. Clinical trials offer hope and the promise of innovative new treatments. Without people who volunteer to participate in clinical trials, this would not be possible. It's not enough to wait for someone else to act. We all have a role to play. We all have a responsibility to each other and future generations. That's why I'm in.
Salvador.
Thank you, Gary. Thanks for the invitation, but more than that, thanks for your vision. Thanks for being a true partner. As you pointed out, we came here last year with a promise, and the promise was to bring the industry together with the National Minority Equality Forum, bring these two organizations together to see how we can begin to tackle what I define as a major crisis that our country is facing. And that's the clinical trial participation crisis. We know that, and you've seen some of the numbers in the video, that overall in the United States, less than 10% of the population is involved in a clinical trial. This number becomes even more dramatic as we focus on what I prefer to call as underrepresented population, going to like 4% in the African American or 1%, again on average, depending on the disease. We feel that this is not acceptable, that we need some strong action to change that. That has always been the case, but it's even more important at a time like this, at a time where the demographic of our country are changing, and we heard that minority perhaps is not the right word to use anymore. At a time where we're really moving towards personalized medicine, at a time where we are going to have an entire new segment of population getting access to medicine. None of this innovative medicine can be really effectively proved to be effective unless they are properly tested in a population that really represent those that eventually will have access to them. And that means that the population that we have in clinical trial has to be represented of the changing demographic. That is very important from an issue of disparity, but it's very important from a scientific issue. So what is really I mean? I mean it's the product of a partnership, of a true partnership, industry-aligned partnership and the National Minority Equality Forum to improve health, this is about public health, by increasing clinical trial participation, particularly among those underrepresented population, including individuals of various race and ethnicity. I want to focus on your attention on two elements here, which have been pointed out by Dr. Ko and others in the previous presentation. This is really a patient-centered and community-focused effort. I think those are two elements to keep in mind. Patient-centered, at the end of the day, it's absolutely important. You know, the patient have to build better awareness about what entails participating in clinical trial for them, for their family, for their children. And make sure that they consider that as being really part of the overall care. The other aspect is community-based, and Dr. Ko just mentioned really health doesn't start in the physician office. It doesn't end in the physician office either. It really starts in the community. And I think that community involvement, it is a strong element of this campaign. It's really what is needed to move the needle in this space and make the difference. We had a very successful launch on March 22nd at the National Press Club. In addition to Gary and our own John Castellani presented their views, we had Dr. Cardenas, chairman of the board of Doctors Hospital Renaissance, providing the perspective of a point of care where I would just say clinical care and community work are already integrated. And highlighting how the progress that they made in addressing diseases that are disproportionately affecting the Hispanic community. And Dr. Tran, which I had the pleasure to see here, the CEO of and President of the National Council of Asian Pacific Islanders Physicians, provide a very, very important perspective about how essential is the relation between the patient, the physician, and the healthcare professional if we really want to move the needle in this space. One thing I mentioned before is that this is really a patient-centered campaign, but from the beginning was meant to really target the community, but also the physician community, the healthcare professional community. We know from data from Research America that really less than 22% of patients have ever heard about clinical trials from their physician. But up to 2/3 of the US population would consider participating in a clinical trial if they would hear about that from a physician. But really what was the highlight of that launch was the presentation from patient Avril Anderson. She was the true advocate. She really meant what this effort is about by really describing how clinical trials change her life from a death sentence into really the ability to have a normal life, great quality with her family, her loved one. There was a great sentence, actually, that Avril mentioned during her presentation, which I think is very powerful, and I'd like you just to, keep it in mind every time you speak to a neighbor, to a friend, to just in your work. What I will say is that really today's cures are yesterday clinical trials, and today clinical trials are tomorrow cures. I think if we even just try to, embrace that in what we are doing every day, that is a very powerful message to get out in the community. A key element of this campaign is the strong digital media component, all the way from a dedicated web portal, which is really the entry site, to get a lot of information and tools, as well as explore opportunity for participation in clinical trial, to a very heavy social media platform. And you can see here a snapshot of some initial metrics of success that show really the magnitude of the uptake that we had within only a month for this initiative. Now, this is a very important thing to keep in mind. First of all, because I guess one thing that it is important to consider overall in healthcare is that we need really to make sure we do better use of the tools that we have at our disposal with technology, same way that other sectors have done it. I think we are kind of a little bit behind that. And in a space like this, as I will comment later, this is even more important. The second is that one thing that we learn is that those same communities, those same population that are disproportionately affected by certain disease, that are underrepresented in clinical trial, are some of the fastest growing community and user of internet. So the digital media component is absolutely essential for us to pursue in the campaign as a major driver of awareness. I want to mention awareness just for a moment. If you really look at the why, and again, I came here today, as Gary pointed out, to show that we really acted on a promise. But as we act, we also continue to learn, and that's how we build the campaign of effort. In most cases, it's that lack of awareness that has been the primary, really, obstacle to this increased participation. Now, awareness goes all the way to understanding what a clinical trial is, to understanding where clinical trials are, what participation means, to correct perhaps some misunderstanding about clinical trials. But the other aspect, I guess, that as we continue to learn, we realize it is absolutely important, it's the connectivity. We know that not always we have a direct link between the physicians, the patient advocacy organization, their family, the points of care, and so on. Now, a campaign like this, which, again, I want to point it out, it's not a PR effort. It's really an education and engagement effort that has really the goal of leveraging all the different tools from communication to outreach to advocacy. Even a campaign like this needs to really look at the future in terms of building something that is permanent. And I guess part of the challenge that we have here is that we don't have a permanent clinical trial infrastructure. You heard this from Gary many times as well. You heard it from some of our member experts. You know, clinical trial networks are often built for the sake of a particular study. The moment the study is terminated, is finished, hopefully finished. In most of cases, you know, the study cannot be completed because of those challenges. The learning, the connectivity, the engagement related to that building of the network is gone. So one of really the goal of the campaign is drive or create a solid basis towards the build-up of the clinical trial engagement network, which really represent the vision of Gary's organization. And it's a very simple idea. It's really, you know, that taking that community center aspect of the campaign towards building, you know, a network which is both a physical network, but also a virtual network, taking, you know, advantage of the tool that I just mentioned of the internet, to really connect all the different players in healthcare, from patient advocacy organization, providers, investigator. We know that we have pockets of where this is already happening. I would just say a small network, and we have a success story there. Our vision and ambition, you know, is hopefully to see this being extended at the nationwide. And I think that would really provide something that is not just going to help move the needle, but it's also make this effort sustainable long term. So I really would like to close with this slide. This is what I like to define the call to action. I mean, I came here and hopefully I showed to you that we acted on our promise. But even the National Minority Quality Forum and the entire pharmaceutical industry addressing this issue, it's not enough. We need champions for this initiative at the individual level. We need champion organization, and we already have identified some We have more than 85 organizations that have already offered to join the campaign and be part of the network. It's pretty incredible within a month. But I think I'd like to close with some of what you heard at the end of the video that I just showed. This is important. It is important from the standpoint of our care, of our being engaged and more proactive in care, the care of our kids, the care of our community. So we really trust that you and your organization will all be champion for this initiative. And outside, we have a table with some of the information that can already be provided here, and Karen Moore can be an important contact for additional information, including several tools for different groups. So in closing, all I want to say is I'm in as an advocate. I'm in as a physician. I'm in as a patient. I'm in as a father. And that's my closing message, and I hope each one of you will share my philosophy and my energy, actually, and Gary's passion and vision for this effort. Thank you.
So I want to underscore a few notes and thank Salvo so much, because it's really his leadership that has helped to bring this forward. And I want to tell you how I think about this and what the opportunity is. So one of my curses is that I'm actually, I love health, but I think of it as a historian, because that's really my training. And when I look at minority health in this country, I realize a lot of the challenges that have confronted us historically. I realize that in 1890, W.E. Du Bois wrote a book called The Philadelphia Negro that talked about health disparities in 1890. Booker T. Washington started Negro Health Week in 1915 because of health disparities. So this is not something that got started in 1980 with Margaret Heckler's report. We've been dealing with health disparities a long time. But here's what's different. And here's where I challenge. And here's the opportunity. I don't know of another industry in this country that has set up a program to solve a problem in the minority community. End of statement. That is huge. That is exactly what our community needs. We need partnerships with industry to solve problems. And one of the problems, and you hear it, the undertone of it throughout this meeting. Number one, we do not have good data about minority health, be it atrial fibrillation, be it diabetes, be it chronic heart failure, be it kidney disease. We don't have the underlying data in terms of the etiology of the disease, good data in terms of the appropriate therapies to use. We can no longer fight health disparities without a good scientific underpinning to the work that we're doing. So some of that's hard work, and that hard work is we got to go do the science. There is no way to get around it. We have to do the science. And so one of the best ways, not the only way, but one of the best ways at the science is through randomized clinical trials. There's a whole philosophical system out there of why we do randomized clinical trials. And for the first time, one of the leading supporters of clinical trials in this industry, they do more than NIH in terms of clinical trials, have said we need diversity in clinical trials because we can see the diversity coming. We can see that the world is changing. And we need to make sure that the products and services that we're about to deliver are safe and efficacious for this emerging community of Americans, diverse community of Americans. And we are willing to do not just educate, but to lay infrastructure, permanent infrastructure, backbone that connect research organizations to community practices, to patients, so that, guess what, we can talk in real time, expedite the whole process by which we conduct clinical trials. And we have to do that for minority communities because we have so much work to do that we need to do it smartly and efficiently. So all of this 11 years that we've been talking about the need to eliminate health disparities, the opportunity sits in front of us. And I say it that way because I'm about to challenge you, because we need you to go home and talk to people in your community, in your family, yourself, to begin to register for clinical trials. I know that's one scary thought. I can hear Tuskegee ringing in the background. I hear it. But you know what the difference is? Here is the fundamental difference. We are part of the body politics now. This ain't 1940 or 1950, right? This is the 21st century, right? And we have members like Donna Christensen. I think there are 42, 43 members of the Congressional Black Caucus. We're down in the state legislature. And we have the capacity to monitor and engage. But even more importantly, we are building the future. Remember, I started this conversation with you this morning about now we have to build for the 21st century. We got access to healthcare. We got that. Need to work on it, but it's there. Big fight about it. A whole lot of people didn't want it, but it's there. Now we have to put the infrastructure in place, and that's what this opportunity is. You cannot go home without walking over to that table and picking up some information about joining the I'm In campaign. You have failed if you've done that, and I failed you if you don't go do that before you leave, because we need you to go home and take that message with you. Because there's no point in building an electronic network and fancy communication tools and lots of analytics and ain't nobody using it. There's no point to it, right? And so I'm going to close with this one important, I think important fact that sort of, to me, summarizes the opportunity and makes it bite-sized. So one of the things that we learned, because we were always piling around in the data, and so one of the things that struck me is that there are 4,500 hospitals in the United States that serve the American people. About 500 of them are minority serving. And what do I mean by that? I mean that 25% of their patient population is minority, and they serve the majority of minorities in the country. So there's 500 hospitals. If we can get them talking to each other in our community, if they can serve as a focal point where information can begin to flow, we can take on health disparities. We'll be able to answer Dr. Kim's question about why does AFib look that way in African Americans and Hispanics. That's transformative. That's transformative. So I'm making the call to action. We need your help. We will fail without you. We can't do this on our own. And industry has stepped up and said, they're in. So you ain't got no excuse. You can't say, oh, Big Pharma ain't doing what they're supposed to do. They're in. They signed, they're there. So now is the opportunity to build. So Karen, if you stand up. Karen has got a little table over there. And Karen, you should take notes. Anybody you see leading the building, and they take it, you get it. Thank you so much.
Thank you, Gary. Thank you, Salvo. And right before we conclude, I would like to introduce you to Traci Ferguson, Dr. Ferguson, who is the Vice President Clinical Services Management for WellCare Health Plans. Thank you very much.
Oops. Thank you. You're welcome. Thank you. Good afternoon. Good afternoon. I want to thank Dr. Puckrin and Congresswoman Christensen for inviting me. I actually met Gary about 3 weeks ago, and he, at a meeting, said, why don't you come and spend a couple, 10 minutes just, giving a brief remarks, and then that turned into turning in my bio, and here I stand today. So thank you, Dr. Puckrin. So what I wanted to talk to you about is what's going on in terms of Medicare Advantage plans. We are rated, again, we welcome ratings by CMS. They use a star ratings plan system from 1 to 5. And what we see, the stars actually judge health plans based on patient outcomes and their performance. And it's actually also based in terms of payment. So if you are a 4 or 5 star plan, you are incentivized and you can have added benefits to your managed care advantage plan. However, again, it's actually public knowledge, and so on the website it will have ratings. And what it also helps to inform in terms of your benefits, and actually with more bonus payments, plans can offer wraparound care instead of just fee-for-service Medicare. But what we also see is that there's widening in terms of the disparity between managed care plans that actually are focused on the low income and minority populations. Only 11 out of the 51 star measures are actually case adjusted. So that is, they're looking at either race or some socioeconomic, but that leaves a wide range of star ratings and metrics that are not adjusted. And what we can see is when you're looking at health plans like my health plan, which we are focused on government-sponsored plans, so that is Medicare Advantage and Medicaid, and the dual eligible, the special needs plans. When you have plans that have a high percentage of special needs, that they consistently have lower star scores. And the reason why I'm here and actually here to bring awareness is that CMS in 2015 has said that if in plans that for 3 years have consistently had stars less than 3, that they can be terminated. And that means that the members and patients in areas that are disadvantaged, low income, will no longer have the opportunity to keep their health plan. And again, that's why I'm here. Looking at, again, several studies just to see what's the data, what is the data showing us. If you have, looking at different socioeconomic factors, whether it's education, whether it's race or low income, that the majority, as you have more percentage of your beneficiaries that don't have a high school diploma, increasing minority, and also of low income, that they have lower control over diabetes, high cholesterol, and high blood pressure. And these are the metrics, in terms of control metrics, that are triple weighted. So here, if you have a percentage in terms of your population, if you are serving, if you're a provider or hospital, if you have a large portion that are low income, either on Medicaid, Medicare Advantage, and the dual eligible, haven't completed high school, and a minority, that, again, trying to control them no matter what you're doing, that there are some socioeconomic determinants that are not addressed in the current star ratings program. And the Harvard Vanguard Medical Associates in 2008 looked at a study and tried to see, well, could it be because one physician, if you had a panel of patients, is the difference between the care that they're receiving in terms of diabetes care, in terms of control, was it because you had this difference in between Caucasians and African Americans, or was there a difference in the physicians? And what's seen in this study is that 2/3 of all of the differences were not related to what the physicians were doing. They had the same panel of patients, but they still had 2/3 of the difference in their treatment. And so what I wanted to bring to your attention is that there needs to be a change in terms of how in terms of the star ratings. That CMS is moving, again, we applaud their movement to actually incentivize health plans to actually continue to better serve the communities. But what we're seeing is that by bonusing just those plans with 4 or 5 stars, you're actually going to be shifting potential dollars from the disadvantaged, from the low-income areas. And we want to have CMS just to bring other people to the table as we are looking to see that they take fully into account the racial disparities and the social and economic disparities that exist. And recently, in 2014, the National Quality Forum had recommendations. Basically, those recommendations, again, reiterated what we've been seeing, in terms of a practitioner, when you have your patients, you can do the same thing, the same types of medications, but for other things that are outside of your control, you don't necessarily get the control in terms of your diabetes, your high blood pressure, or cholesterol. And the problem that, in terms of negative consequences, if we don't do anything, is that health plans, physicians, hospitals will be labeled bad performers. And that, again, there's going to be a shift in funding away from the inner city, away from the patients that we love and care for, to the more affluent, and we'll have, again, plans that will see this happening, larger health plans actually leaving areas and no longer offering health care plans in the areas to serve our members. So basically, what I wanted to, again, just to reiterate that I'm so glad that Dr. Puckrin invited me to come because, again, I think this is something that as a health plan, we need to partner with providers, we need to partner with our Congress in order to bring awareness that to know that there's urgency to this because it's in the books to again, terminate plans that have consistently, for 3 years in a row, had star scores less than 3. But again, we don't want that to happen. We're here, we're dedicated to serving, and we want to make sure that we are at the table when they're making these decisions. So thank you. Oh, okay. Nope. Sorry.
I'm sorry, we're running a little late. That concludes our luncheon. Thank you very much for your kind attention. We're going to start our CME and plenary session. One question.
Just real short, because in fact, I don't know, as fast as things are going, you can get lost. And I really didn't get into your presentation until halfway in because I was still being dazzled by Gary's presentation on let's get in the plan. But what you're talking about is, when we were talking about giving report cards to make it more community sensitive, okay? You're saying, and so is the forum, that we need to look at how they're and what they're using to grade
score
the plans,
yes,
right?
Correct. Yes.
But what I don't understand is this. Blue Cross Blue Shield in Chicago, they running into the hood. They ain't running away from the hood. So how do you get the position that in the event that we don't do something, well, I think we got to do something. But what I really want to do is I don't want us to get confused, and I think we get people confused, and the community get confused when they don't understand the reason why we're doing it. It seems to me the reason we ought to do it is because we need to know when we're getting a good plan and when we ain't getting a good plan, period.
Correct.
The fact that the fact of the matter is Blue Cross Blue Shield, all the big boys, because WellCare, that's Harmony, right?
Yes.
We want to talk about how we're going to sustain Harmony and other plans in a competitive environment. But I just need you to respond if you can, because I really want to get into this let's go get into making sure that the report card's right.
Correct. So again, in terms of response, what we want to do is we want to come to the table. We know that we want to be graded, but we want people to know that in terms of the proportion of low income and minority. Blue Cross Blue Shield, they're commercial, so they have a lot of commercial dollars, and if you look at in terms of their spectrum, they're able to utilize that commercial ranking system to have a higher score. They have more money for other activities. But in terms of for health plans that are completely government sponsored, we're playing with the big boys, and so what we need is we have a larger percentage in the inner city. We have a larger proportion across all of our company, so that when you look at that, it's an imbalance between, we don't have the commercial dollars to actually pour in to give additional resources. So that's what we want to do to let them understand that, if you're dedicated to this population, low income, that we need additional resources because we don't have those commercial dollars to bring in. Okay. Thank you.
Thank you very much. We're going to start our CME and plenary sessions in 5 minutes. Thank you.